A very good evening to one and all. I am Arpita from the IJCP group who welcomes you all to yet another webinar on the topic comorbidities and psoriasis as we are celebrating the World Psoriasis Day. And yes, we have with us someone who is an expert in this field, none other than Dr. Anil Ganju, sir. It's an honor for me to welcome sir and to introduce him to everyone. So,
Yes, sir.
yeah, no, sir, just a minute. So, sir has done MBBS, MD in dermatology, venereology, and leprosy. Is the director of Skinnovation Clinic, the World of Aesthetics, Model Town, New Delhi. He is presently the president of SAARC AAD. So, sir, with this very brief introduction of yours, I would request you to please start with the topic for today. Over to you, sir.
Thank you, Arpita, and thank you, IJCP, for giving me this opportunity to connect with your audience. It's a real pleasure doing that. And today we talk about a very important subject, psoriasis, which is becoming more and more common in our day-to-day clinics now. And not only the basic psoriasis as a skin disease, but psoriasis associated with so many comorbidities now that we are coming to know that's a more complex disease than just a skin disease. So we are going to discuss these comorbidities today beyond the involvement of the skin in these patients. So, friends, psoriasis is a chronic, relapsing inflammatory condition of the skin, which is characterized by these oval red plaques that exhibit silvery scales over them that are shed off very, very easily, and then they leave a little bleeding spots underneath. Immunologically, it's basically happening because of infiltration of the skin by T lymphocytes that release inflammatory mediators and lead to proliferation of the keratinocytes and an inflammatory response in the skin. Uh, it's a very difficult disease for the patients who have it because it remains lifelong, has a huge impact on the quality of life associated with substantial discomfort, stigmatization, and limitation of daily activities. There's problem with day-to-day activities like bathing, sports, sleep, work, sexual relationships, etc. It basically is associated with a heightened mitotic activity in the keratinocytes of the skin. The basal keratinocytes proliferate at a speed 50 times more than the normal keratinocytes, and they migrate up into the superficial layers of the skin, forming the stratum corneum very fast, which happens in a matter of just 3 to 5 days, as against the normal 28 to 38 days, which normally the keratinocytes take to reach from the basal layer to the top layer or the stratum corneum. And histopathologically, we see hyperkeratosis and parakeratosis in the epidermis. We see neutrophils infiltrating the epidermis, forming small abscesses. These are known as cogoges neutrophilic abscesses. And there is associated thinning of the epidermis over the dermal papillae. There is proliferation of vessels within these dermal papillae, which leads to easy bleeding in the skin, and then there are elongated retic ridges. If we look at the etiology, it happens in those who are genetically predisposed, and then there are environmental triggers like UV radiation, like microbes, like trauma, uh, pollution. All these can trigger this inflammatory response and keratinocyte proliferation in those who are genetically predisposed. And the main pro-inflammatory cytokines that promote the disease include IL-23, IL-17, and also tumor necrosis factor alpha, interferon gamma, interleukin 22, etc. All of them are associated with increased proliferation of keratinocytes and an inflammatory response that leads to the formation of that inflammatory plaque. And this is a diagrammatic representation comparing the normal skin on the left side to the abnormal skin of psoriasis on the right side. You can make out that on the left side, there's a normal laying down of the keratinocytes as they divide in the basal layer and move up into the stratum corneum. And stratum corneum is very well formed, well laid out. Compared to the diagram on the right, you see that the epidermis is packed with keratinocytes because there's a hyperproliferation happening. The cells are moving up fast into the upper layers. They are immature, and there is neutrophilic accumulation in the stratum granulosum, leading to forming those neutrophilic abscesses, and the stratum corneum is all disorganized and scaly. That's what gives the clinical picture of psoriasis. These are the clinical variations that we see. The commonest is the chronic plaque psoriasis, which happens in up to 80% of the patients. We have nail psoriasis happening in a good 50% of the patients. Uh, uh, there are people who have joint involvement, 7 to 40%, palmoplantar psoriasis in 4%, erythrodermal psoriasis in 2, guttate psoriasis, which is presentation with very, very small lesions all over the body suddenly, in up to 12%, and then inverse psoriasis, where psoriasis involves the flexures, is seen in up to 2 to 6% of the patients. The disease is quite common, and if you look at it globally, about 125 million people across the globe are affected, which means about 3% of the population worldwide is affected by this disease, and about 3% of them have about one third of them have a moderate to severe disease. And India is not very much behind. In fact, Indian prevalence is even higher. We have about 25 million Indians affected with this disease, which means 20% of the global burden is in India alone. And 90% of these patients have chronic plaque psoriasis, and 10% are the ones who have a more severe disease. More men are affected than the women. Now, if we look at the history of understanding this disease in 2000, about 2000 years ago, when this disease has been talked about first, it was considered to be a form of leprosy, and in 1841, Hebra was the first who used the term psoriasis, and then in 60s it was found that there is a epidermal proliferation happening in the disease. In 90s, they discovered that in addition to the proliferation, we also have an immunological disturbance within the epidermis, and then now finally we know that it is not only a skin disease, but it is a systemic inflammatory disease associated with comorbidities. But still, generally, it is believed that psoriasis is just a skin disease, but that's not really true. Let's look at what is happening. Psoriasis actually is a progressive systemic inflammatory disorder that impacts the body much deeper than the skin. There are visible manifestations that we've already talked about. There are invisible manifestations, there are comorbidities, and there's a huge impact on the quality of life. All this put together, the psoriasis becomes a very serious disorder. Now, scalp psoriasis, nail psoriasis, palmoplantar psoriasis, these are the visible manifestations. Psoriatic arthritis is an invisible manifestation which happens in a good 30 to 40% of the patients. There is spondylitis happening in up to 25% patients. There is dactylitis happening in about 50% of the patients. And many a time, very commonly, the Achilles tendon inflammation known as enthesitis happens in up to 67% of the patients. These are the invisible manifestations which are not seen on the surface. And these are the comorbidities. Most common is depression, because these patients are hugely affected psychologically because of their disease. They withdraw from the society. They are not very happy interacting with the people. They go into depression, and it has been seen happening in up to 79% of the patients. About 42% will have type 2 diabetes, up to 60% will have metabolic syndrome. Obesity is common in up to 32%, and about 13% will have cardiovascular disease, and about 32% will have one comorbidity, up to 10% will have two, and up to 8% will have more than three comorbidities at the same time. So that's the importance of comorbidities in psoriasis. The quality of life is affected to a large extent. In this study, where a questionnaire was given to the patients who were suffering from moderate to severe psoriasis, 75% said that the disease had a moderate to large negative impact on the quality of life. 60% said that they are missing a good number of days at work, more than 26 days at work per year, which means that it affects the quality of life. A 94% of the patients said that psoriasis is a problem in their day to day life. 88% said that it has an emotional effect and affects them emotionally. And 82% said that it interferes with the general enjoyment in life. Now, comorbidities and psoriasis is a very complex situation. We don't know whether psoriasis causes comorbidities or the comorbidities cause psoriasis. In fact, both seem to be, adding to the other. Uh, Okay. Uh, the various mechanisms by which psoriasis is associated with a cardiometabolic, situation is by having common inflammatory pathways between psoriasis and metabolic syndrome, by secretion of what is known as adipokines, leading to proliferation of adipocytes in the body, by the promotion of insulin resistance in patients of psoriasis, by angiogenesis and oxidative stress, by hypercoagulability, all of them, and the risk factors like hypertension, diabetes, dyslipidemia, obesity, metabolic syndrome. Add to that the medicines that are given for psoriasis, like methotrexate, TNF alpha blockers, etc. All of them can increase the possibility of development of myocardial infarction, stroke, and cardiovascular death. So these patients are at a risk of higher risk of cardiovascular disease and cardiovascular accident like myocardial infarction, cerebrovascular accidents like stroke, and cardiovascular death happening. Okay. The metabolic syndrome is a condition which has risk factors for lifestyle related diseases like obesity, like hypertension, like glucose intolerance and diabetes, like dyslipidemia, all happening in one patient and then leading to an increased risk of cardiovascular and cerebrovascular disease. And this metabolic syndrome definitely has a higher incidence in patients of psoriasis. Obesity is one of them, and it is important to understand the epidemiological relationship between obesity and psoriasis. A study done by Shetty et al. Involving more than 78,000 women, out of whom about 900 had psoriasis, showed that the fat and weight gain were definite risk factors for development of psoriasis, and a high body mass index of more than 35 kgs per square meter displayed a definitely higher risk of development of psoriasis. Such studies suggest that preventing weight gain and promoting and maintenance of normal body weight and reduction of body mass definitely reduces the incidence of psoriasis. We have also seen practically that patients who are obese and whose disease is not getting under control with the conventional treatment, if they are advised to lose weight and they do lose weight, it definitely improves their response to the medical therapy. Hypertension is another killer condition which is a part of the metabolic syndrome and has been found to be associated with patients of psoriasis. It is a well known risk factor for cardiovascular disease, contributing to the development of myocardial infarction and ischemia, also to stroke and cardiovascular death. Several studies have now shown that there is a positive association between psoriasis and hypertension, and reduction of psoriasis definitely reduces the incidence of hypertension also. Diabetes is another association of metabolic syndrome, which is again related to psoriasis. Uh, Epidemiological studies have suggested that psoriasis is associated with increased incidence of type 2 diabetes, depending upon the severity of psoriasis. Ikumi et al. Showed that the skin severity of psoriasis was associated with a higher blood glucose level, a higher HbA1c, and this correlated well with the severity of psoriasis and the level of cytokines like interleukin 17, and use of biologics like interleukin 17 blockers was associated with not only in improvement in psoriasis per se, but also in improvement in the glucose metabolism in the blood. Also, the commonly used biunide hypoglycemic drug metformin, which is used as a first line drug now for type 2 diabetes, has been seen to also improve the psoriasis in patients who are affected by both. Now, blood lipids are also a common, problematic situation in patients of severe psoriasis. These patients have exhibited a decreased level of HDL, a raised level of LDL, VLDL, and triglycerides. And we all know that HDL is the good lipoprotein or the good cholesterol. It improves cholesterol transport and decreases the cholesterol levels in the blood. It has antioxidative properties and anti inflammatory properties. and these properties are reduced in chronic inflammation such as psoriasis. And conversely, anti-psoriatic therapy, particularly biologics like interleukin 17 blockers, restore the composition and function of HDL in these patients. So these patients are at a higher risk of cardiovascular disease because of deranged lipid metabolism. Another condition that has been found to be very commonly associated with psoriasis, particularly severe psoriasis, is the non-alcoholic fatty liver disease, which basically is the deposition of fat in liver and derangement of liver function in absence of alcohol consumption or in absence of any other common cause of liver disease like drugs. Gisondi et al. Reported that a higher incidence of ultrasound diagnosed non-alcoholic fatty liver disease to the tune of about 47% in one series of moderate to severe patients of psoriasis, about 130 of them compared to 28% in the age and sex matched normal individuals. The pathogenic link is probably the chronic inflammation and the chronic peripheral insulin resistance that is seen in psoriasis that leads to the development of the non-alcoholic fatty liver disease also. The cardiovascular disease is also common. It has to be, because I've already told you the lipids are deranged. There is a higher incidence of glucose metabolism disturbance and diabetes. All that contributes to cardiovascular disease, higher risk of myocardial ischemia and infarction, and even cardiovascular death. Particularly dyslipidemia, obesity, diabetes, all these add to this problem. And uh, there's a concept of psoriatic march in these patients who have severe psoriasis. Usually, severe psoriasis is associated with systemic inflammation, leading to increased insulin resistance, vascular endothelial damage, atherosclerosis happening within the vessels, coronary vessels, and then finally myocardial infarction. And this is typically known as psoriatic march. And add to that obesity, which is a common association again, that adds to the problem and further aggravates the condition. Now, as I already talked about biologics, nowadays use of biologics has been seen to reduce the systemic inflammation associated with psoriasis and has been seen to reduce the risk of cardiovascular disease in these patients also. And biologics like TNF alpha blockers, like IL-17 inhibitors, like secukinumab, have been found to reduce not only the disease process but also systemic inflammation and the risk to cardiovascular disease. So nowadays we promote use of biologics in patients of severe psoriasis because that reduces the risk of cardiovascular disease also. Now, beyond the cardiovascular disease, we also have the involvement of the cerebrovascular system, and these patients, because of the systemic inflammation, have associated atherosclerosis happening in the cerebrovascular system and increased incidence of strokes and deaths because of that. Again, biologics like IL-23 and IL-17 blockers have been found to reduce the risk of stroke in patients of psoriasis. Therefore, friends, psoriasis definitely is not just a skin disease. It's a systemic inflammatory disorder, has huge number of complications. Particularly of importance is metabolic syndrome. And among these, the cardiovascular disease is definitely the most important because it can be associated with a lot of morbidity and even fatality. Dermatologists have to keep their eyes open and should work with cardiologists to elucidate the condition in psoriatic patients. However, a cardiovascular examination may not be important in all the patients, so you need to be aware of the patients who are more likely to develop these complications. So look for patients who are obese, look for patients who have a bad lifestyle, look for patients who have signs of insulin resistance. Then such patients should be worked up for a cardiovascular disease also. Their lipids should be done, their diabetic profile should be done, their cardiac studies should be done, their cerebrovascular studies should be done, and if required, these patients should be given preferably agents like biologics that have a great impact on the systemic inflammation in addition to the skin inflammation to control the disease. Therefore, friends, to conclude, psoriasis is definitely more than skin disorder. It is associated with visible manifestations that we see on the skin, like plaques of psoriasis, erythroderma, pustulation, etc. It is associated with invisible manifestations like involvement of the bones, joints, tendons, etc. It is associated with comorbidities like cardiovascular disease, metabolic syndrome, cerebrovascular disease, etc. And then it has a huge impact on the quality of life. And it seems that the newer drugs, biologics, definitely help us manage psoriasis of the skin and also the comorbidities better than the conventional drugs. Thank you very much for your kind attention. Over to you, Arpita. If you have any questions to take, please.
Right, sir. Sir, thank you. Thank you so much for the wonderful presentation. We have received a few questions meanwhile.
You want to move? You want to move?
I think sir has already answered, but yeah, this question has come. How do common comorbidities such as cardiovascular diseases, metabolic syndrome, and obesity impact the treatment approach for patients with psoriasis?
Come again, please. Sorry, Arpita. I didn't get that question. Can you? Yeah.
So, how do common comorbidities such as cardiovascular diseases, metabolic syndrome, and obesity impact the treatment approach for patients with psoriasis?
So if you suspect that systemic inflammation is happening, patient has associated comorbidities. One, you have to have a multidisciplinary approach. You may have to involve a cardiologist. You may have to involve a neurologist, and then you have to be aggressive on your treatment because you should be controlling the systemic inflammation in addition to the cutaneous or skin inflammation. And nowadays, the newer drugs like biologics help us do that. So if you give them biologics early in the disease, you will be able to control the systemic inflammation also. It's basically inflammation only which causes all that vascular complications associated with this disease. So if you keep the inflammation under control, the comorbidities will be under control. And then lifestyle becomes a very important, lifestyle management becomes a very important part of the treatment in these patients. They should be following a healthy lifestyle, healthy food habits, exercise daily. That goes a long way to reduce comorbidities and the inflammation associated with psoriasis.
Right, sir. Thank you so much, sir. The next question is: what are the latest insights on link between psoriasis and mental health conditions such as anxiety and depression, and how this needs to be addressed in the treatment plan?
As I said, it has a huge impact on the quality of life, the mental well-being. These patients generally have a huge stress and are distressed because of the disease. They don't want to show their disease to their friends or colleagues, etc. They are usually withdrawn because of the disease. So a huge impact on the psyche of the patient. They are anxious about their disease, what will happen next, whether it will spread, whether it will go to their family members, whether it will go to their children. All these factors have an impact on the psyche of the patient. And then many of them go into depression. I had shown you up to a good percentage of up to 79% will have some degree of depression or the other. So the psychological component is a huge component of the disease, and we have to keep our eyes open. Many a time we give them mild anxiolytics and antidepressants to take care of their anxiety and depression, but if it goes out of hand, then we have to again work with our colleagues like psychiatrists or psychologists to help these patients out.
Right, sir. So the next question is psoriasis completely curable?
See, it's a genetic disorder. It is in the genetic makeup of the patient. No, it will not go completely. It will always have a tendency to come back. But we have so many drugs now, which they say can produce 100% clearance, or at least a 90% clearance within a few months, and then it can be kept under control. So you have to treat it, bring it under control, and keep it under control. It's not that it will go for good. You have to be on the follow up, be on some kind of maintenance treatment to keep it under control.
Right, sir. So it means a lifetime treatment plan is required for such patients.
Not necessarily. Maybe just a good care of the skin is required lifetime, and whenever the disease flares happen, at that time we give them more aggressive treatment, or keep them on something very mild throughout. Yes.
Right, right, sir. Sir, regarding the diagnosis of the issue, the thing is, patients come very late to the dermatologist because sometimes the flares they appear, they seem like dandruffs. So the patients they keep on ignoring and maybe they apply shampoo and everything. So what can be done to make more aware of such conditions?
I think programs like these can go a long way to spread the awareness, and these days social media, etc., is doing a lot to spread the awareness. Yes, people should be aware about not only psoriasis but other common disorders that should be brought to the notice of the doctor as early as possible. That gives the patients more help, that helps the doctor control the disease better at an earlier stage, and that has a better outcome ultimately. So awareness is important, and but having said that, whatever stage the disease comes in at, we generally are able to control the disease unless it has done some major damage like a cardiovascular accident or something. Then things may be very late, but otherwise it's never late to see a doctor.
Right, sir. I think there is one last question. In patients with multiple comorbidities, what are the key considerations when choosing between biologic therapies and other systemic treatments for psoriasis?
You see, if you are having a patient who is likely to have a comorbidity, an obese patient, a patient who is showing definite signs of insulin resistance, a patient who has a history of bad lifestyle, who is smoking, etc., then you tend to do a thorough examination to exclude comorbidities and treat the comorbidities. And patients who have signs of systemic inflammation or have severe disease definitely should be getting more advanced treatment like the biologics, which have the ability of reducing systemic inflammation to a large extent. Particularly the IL-17 blockers now available are particularly useful in reducing systemic inflammation. In such patients, we give specific medication only, which would help to control the systemic inflammation.
So, can I take one last question?
Yeah, yeah, please.
Sir, the question is to prevent and to reduce the itching, we generally give antihistamines of first and second generation. So, how long do we need to continue that with the patients, and what can be the side effects?
One good thing about psoriasis is that it doesn't have a very severe itch, but sometimes, yes, they do have itching also. And you can give antihistamines for a long time. Generally, they don't have side effects. The first generation antihistamines definitely have sedative action, and that can affect the day to day quality of life, the alertness of the patient, the output of the patient, etc. The second generation antihistamines are relatively safe, they are non sedating, and it's better to give them, and you can use them long term, they are quite safe.
Right, sir. Thank you, sir, for thank you for answering all the queries.
Thank you,
And
Arpita.
yes, so with that we come to an end. I would like to thank you from the bottom of my heart, sir, for taking out your time and putting so much effort in making the presentation and then answering all the queries. So, sir, thank you so much from all the viewers.
Thank you.
And of course,
Welcome
thanks to
and
all
all
the
the best.
audiences for coming in, for joining us, and for putting up their questions, for engaging support. Thank you all. Thank you so much, sir, once again.
Thank you, Arpita. Bye bye.